Hi, everyone. Thanks for tuning in and thanks for your interest in implementation research. I'm Lisa Juckett, and the way that this presentation is structured, it's designed to serve as a complement to the wonderful presentation that we heard from Laura Damschroeder earlier this month. And so naturally, what I'll be talking about relates to the Consolidated Framework for Implementation Research, specifically how I've been involved in a handful of projects that have identified contextual determinants using that CFIR terminology, and then using that CFIR terminology and those determinants to inform our selection of implementation strategies. So before I go forward, though, I wouldn't feel comfortable without first acknowledging some key groups and players whose contributions have been instrumental in two of the projects that we're talking about today. So the first shout out goes to the American Occupational Therapy Foundation, specifically their implementation research grant mechanism, which funded one of the first study that I'll be talking about. And the co-investigators on that work include Drs. LeaRRn Wengard, Meredith Banyos, and Amy Dara, all with The Ohio State University. And then the second project I'll be sharing is an initiative started out by the American OT Association, particularly through their evidence-based practice department. And so much appreciation goes to what we like to call our knowledge translation toolkit team. So first, a little bit of a roadmap for what to expect over the course of the next 50 or so minutes. Even though it's wonderful to hear about the Consolidated Framework for Implementation Research, as well as the updates to part 2 of the CFIR, I do feel like sometimes the CFIR really does come to life through different case examples or case illustrations. And so what I'll be talking about in these 2 different illustrations today will be how we've evaluated CFIR determinants. And when I say determinants, admittedly throughout the presentation, I might use terms such as barriers, facilitators, constructs, factors. So first we'll talk about how to evaluate those CFIR determinants or those determinants of implementation. We'll also talk about how you can use those determinants to then guide your selection of implementation strategies. And then lastly, and what we'll actually wrap up on is a conversation that hopefully we can expand into our Q&A session about how to evaluate not just implementation outcomes. And I promise I won't get into the weeds too much about implementation outcomes because that could be a talk in and of itself, but rather how do we evaluate these implementation determinants? And in an effort to try to be helpful to you all, because I do appreciate you tuning in, I've tried to intersperse throughout the slide deck different links, different resources, different tools that hopefully you might find useful as well as you embark upon your own implementation projects. And I know that we are very accustomed these days to virtual meetings, virtual webinars, as well as just general remote learning. And so I've tried to be more mindful about the different strategies I've been using to disseminate information, communicate information in this virtual format. So I'm going to kick us off with a new strategy that I'm trying out here for the first time. And that's just with a quick story that relates to the content that we'll be talking about. So this right here is the Ohio State University Wexner Medical Center. Around the same time that the CFIR was published, I landed my first job as an occupational therapist in this building right here at Ohio State's inpatient rehab facility, treating primarily stroke survivors as well as patients with traumatic brain injury and spinal cord injuries. A mere 50 meters away in this building, there were occupational therapy researchers who were developing and testing interventions designed to increase the sensory motor function of the post-stroke upper extremity, and those researchers were evaluating those changes in function with standardized assessments. So one might think that the research that was conducted just across the way would just naturally inform the work that I was doing in my practice. But for the sake of being totally transparent, that did not happen. And in hindsight, I can tell you that there were a multitude of multi-level barriers that hindered my ability to do so. And those barriers pertain to characteristics of myself as an individual, barriers that might pertain to characteristics of the intervention, characteristics of the inner setting within my facility itself, characteristics of the outer setting, such as the greater healthcare system, as well as just factors that pertain to the complexities or the complex process of trying to implement evidence into real-world care. And I'm able to rattle off those terms because we have language today that the CFIR has provided us. But back in 2009, 2010, we weren't necessarily as privy to that language. So I found it quite interesting in Laura Damschroeder's talk when she mentioned that when she and her colleagues initially set out to develop the CFIR, they underestimated the value that it would bring to the entire field of implementation science, because it provided the field with a uniform language for how to describe these determinants of implementation, these barriers to and facilitators of implementation efforts. And so today, we have language that speak to these the outer setting domain, the inner setting domain, characteristics of an intervention, characteristics of an individual, or the general process that might impact our ability to implement evidence into practice. And so the CFIR itself really pushed the field of implementation science forward by providing that uniform nomenclature. And we've seen similar efforts take place in the implementation science field. If you're familiar with the Expert Recommendations for Implementing Change project led by Byron Powell, he and his team attempted to put language, and they have put language, around a set of 73 different implementation strategies. Enola Proctor's work in 2011 put language around 8 different implementation outcomes, ranging from adoption, acceptability, all the way down to sustainability. And it's important to have this language in the field of implementation so that we're able to communicate not just with ourselves, but to other disciplines, so that we know what factors might influence implementation, what strategies are used to optimize implementation efforts, and then ideally those strategies lead to improvements in implementation outcomes. And so the CFIR really has pushed the field of implementation science forward. But I won't gush any further about the CFIR, and rather let's just hop into our first case illustration, specifically looking at outcome measure implementation or standardized assessment implementation in the stroke rehab field. And compared to the second case illustration that I'll be talking about, this one is more of your traditional implementation study design. It is a pilot, but it is more of that kind of traditional research study, at least with an implementation slant. So first, a little bit of background. We know that stroke is common, and every 40 seconds an adult in the United States has a stroke, and we expect to see an increase in stroke with the growth of the older adult population, given that stroke is more common in individuals over the age of 65. We know that stroke is the leading cause of long-term disability, and we also know that stroke survivors, 80% of those stroke survivors experience upper extremity impairments related to their stroke. And you'd think that because of the high proportion of individuals who do have those upper extremity impairments, and those impairments might manifest as in sensory impairments, motor planning impairments of the shoulder, arm, wrist, or hand. With those impairments present, one might think that occupational therapy practitioners, who are often tasked with treating and managing the hemiparetic and hemiplegic upper extremity, one might think that those practitioners would frequently implement evidence-based assessments to capture upper extremity function at baseline, and then use those same assessments, re-administer them to monitor changes in upper extremity function over the course of a stroke survivor's rehabilitation trajectory. But we know from some of our preliminary data, data from over 1,500 OT practitioners across the US, that when it comes to evidence-based assessment use, only 2.5% of our sample indicated that they routinely used evidence-based assessments to capture upper extremity function. And when we break out these numbers a little further and look at 2 specific standardized assessments, again, evaluating upper extremity post-stroke function, we see that of our sample of over 1,500 OT practitioners, only 5% indicated that they routinely used the Fugelmeyer assessment of the upper extremity, and only 2.5% used a test known as the Action Research Arm Test, which I might refer to as the ARAT throughout the rest of our time together here today. And we focus on these 2 because these 2 have been endorsed or have been widely encouraged for use by international groups of stroke rehabilitation research and stroke rehab practice experts. But so certainly with these proportions in mind, this low rate of use, there's room for improvement. And this is not a dig on the OT profession at all. I myself did not use either of these assessments nearly as often as I should have when I was back in full-time practice. But there's certainly room for improvement, and we want to do the work to try to improve the rates of use amongst our OT practitioner colleagues. So, which takes me into our first study here. which we refer to as our ISTROM study, implementation strategies for outcome measurement. And the purpose of this study is to deploy a package of implementation strategies designed to increase practitioners' adoption of the Fugl-Meyer assessment, just the upper extremity component, not the entirety of the Fugl-Meyer, and the action research arm test across the stroke care continuum. And when I say stroke care continuum, I'm referring to the acute care setting, inpatient rehab, as well as outpatient rehab with our clinical partners at Ohio State University's Wexner Medical Center. And given the nature of this grant being funded through the American OT Foundation, we are only looking at the assessment use patterns of occupational therapy practitioners. So again, our goal here is to deploy this package of implementation strategies to increase adoption of these two assessments. And so you might ask, well, what are those strategies that you plan to deploy? Which takes us into our first piece here about evaluating those determinants of implementation, because we need to evaluate determinants of implementation to then determine exactly what strategies will help us overcome, in particular, implementation barriers. So I've been part of projects where you can go about evaluating these determinants or these barriers and facilitators for implementation in several different ways. One might be through the collection and analysis of qualitative data, so focus groups and semi-structured interviews. One might be through administering cross-sectional survey. But what we did for this study was, as a precursor towards developing the grant proposal, we conducted a scoping review of the occupational therapy literature to answer the question, what are the barriers and facilitators that influence evidence-based practice use in stroke rehab, again, specific to the occupational therapy literature. And as we conducted our review and extracted data from our included studies, we mapped those data back to the Consolidated Framework for Implementation Research. And we found that there were several different barriers, but the major barriers really fell within the inner setting domain of the CFIR. And those barriers included access to knowledge and information, or a lack of access to knowledge and information, inadequate networks and communication, as well as a lack of a supportive implementation culture. And so with these barriers identified, my colleagues and I felt confident going into kind of this next phase of developing our implementation study to select our implementation strategies. In Laura Damschroeder's talk, she mentioned her CFIR technical assistance website, the CFIR-guide.org. And if you're not familiar with CFIR-guide.org, I would highly recommend accessing the website, perusing the different resources. Even if you're new to the CFIR, or if you've been using it for several years in different implementation projects, I'd still check it out to take advantage of some of those very helpful resources. And one of those resources on the CFIR-guide.org site is the CFIR-to-ERIC matching tool. And I'll go into some details about that here in a moment. But just rewinding a little bit, a couple of slides ago, I mentioned the ERIC project, the Expert Recommendations for Implementing Change project, led by Byron Powell. And really this project developed a taxonomy, again, of 73 different implementation strategies. And thought being that these strategies can be leveraged to overcome implementation barriers. Byron Powell teamed up Laura Damschroeder, as well as with Tom Waltz and others, to basically assess, based on the perspective of other implementation experts, given this list of implementation strategies, what strategies do you think, based on your expertise, will be most effective for overcoming implementation barriers using CFIR determinant language? And so if you go to the CFIR-guide.org website and you click on the CFIR-to-ERIC matching tool, it'll take you to a downloadable Excel spreadsheet. And at the risk of sounding too simplistic here, here's a screen capture. This is what the tool looks like. So in that middle column there, you've got all the different constructs that are included in the CFIR, organized by their domain. Adjacent to that middle column is just a bunch of zeros. But you, as a user of the CFIR-to-ERIC matching tool, will go in and place a 1 next to your identified implementation barriers. And so for us, for instance, we knew that networks and communication was a barrier to implementation. We also knew that implementation culture was perceived to be a barrier if that culture was unsupportive. And then lastly, we knew that access to knowledge and information was our third major barrier. Again, those barriers were pulled from our scoping review. So then at the very bottom of this spreadsheet, click the query button, and then that takes you to your CFIR-ERIC matching tool output. And this output is generated based on all those data that were collected from those implementation science experts. And from those data, this tool gives you your top recommended or most highly recommended implementation strategies believed to overcome your identified implementation barriers. So for us, based on our implementation barriers, our top 3 implementation strategies were to conduct educational meetings, to create a learning collaborative, otherwise known as more of a activity sharing or knowledge sharing or knowledge building type of collaborative, and then to identify and prepare champions. In this case, those champions would be outcome measure champions. And while it's great to have these recommendations here, we have to take these recommendations with a grain of salt. And Laura Damschroeder said that herself, because when she and her colleagues assessed the perceptions of these implementation experts, what strategies are most effective for overcoming these barriers, there was great variation in those recommendations when they came back to Laura Damschroeder and her team. And so again, we've got to take these recommendations with a grain of salt, but know that it's a great place to start, knowing full well that we're going to have to vet these strategies with our occupational therapy stakeholders, and then also ask if there are additional strategies that we're perhaps not thinking of in order to support their use of implementing both the Fugl-Meyer and the action research arm test in real world practice. So now that our study has started in July this year, we started to collect focus group data from our OT practitioner stakeholders, and also started to have some conversations with our key informants representing the field, the areas at least of acute care, inpatient care, and outpatient care, again, being our 3 areas of interest or 3 target settings. So what we've done in these conversations, in these focus groups, is we've introduced our 3 primary implementation strategies. Again, these are our strategies that make up the ISTROM package. And you've got our conducting educational meetings. So we're asking questions about how do you want these educational meetings formatted? How do you want them to be delivered? In what type of style? How often? What do you expect from your outcome measure champions? And then also, what activities do you want to be included in your learning collaboratives? But in addition to these 3 primary implementation strategies, we've also learned that we need some additional strategies to be built into our ISTROM package. So when we talk to our acute care practitioners, we know that we have to change the record system. So we have to change EPIC in order to allow for our acute practitioners to be able to seamlessly document findings from the assessments that they implement with patients. Our acute practitioners also need reminders indicating when they're expected to implement these different assessments with their patients. And then lastly, we need to adapt recommendations for assessment use. And I bring this up, and I want to be clear that we're not adapting any part of the assessments that we're asking or that we're requesting that acute care practitioners implement. Instead, when we think about these kind of international recommendations for what outcome measures should be implemented and when with stroke survivors, it's not necessarily feasible for the ARAT, the action research arm test, to be implemented in acute care as frequently as it's recommended. It's recommended for implementation at day 7 post-stroke. And if you're familiar at all with the acute care setting, and if you're familiar with the ARAT, you might understand why that's not necessarily feasible, given the resource and time constraints and logistical challenges in the acute care setting. And so for the acute care setting, we're only going to have our practitioners implement the Fugl-Meyer with those patients who have a diagnosis of stroke. In the inpatient setting, we've learned from our inpatient practitioner stakeholders that similar to acute care, our inpatient practitioners need to be reminded when to actually implement the Fugl-Meyer and the ARAT. We need to change the record systems. Our acute practitioners also, or excuse me, our inpatient practitioners also need assistance funding the right equipment required to implement the ARAT and the Fugl-Meyer. And they also require strategies to help them communicate with local opinion leaders. And those local opinion leaders would be those leaders in nursing as well as PM&R, because there's a lot of scheduling challenges in inpatient rehab. You have a lot of different conflicting appointments or procedures that patients have to get to. And so we need to communicate with those nursing and PM&R leaders to make sure that the importance of outcome measurement is really understood and that patients are attending their therapy sessions when they're scheduled to participate in either the Fugl-Meyer or the ARAT on their designated date. And then kind of to follow up with educational meetings, our inpatient practitioners, in addition to the training and the meetings that we'll be providing them, they also wanted to couple that training with consultation, which can be particularly powerful for building the capacity of practitioners to implement evidence into practice. And lastly, what we've learned from our outpatient practitioners and talking with them is that similarly to inpatient and acute, they need reminders. We're changing the record systems currently. We need funding, but one unique strategy that our outpatient practitioners needed was the addition of educational materials, particularly in the form of videos. And that was brought up because practitioners in the outpatient setting might not see a stroke survivor for several months and might need to remind themselves how to administer individual items on the Fugl-Meyer or on the ARAT, and would rather refer to videos that would be available on some sort of web-based platform, as opposed to reaching out to the investigative team, such as myself or my colleagues. LeaRRn Wengert has gone around the world training practitioners on how to implement these two assessments, but these educational videos seem to be a more practical option for outpatient practitioners, as opposed to trying to schedule follow-up consultations or a follow-up phone call with any members of the investigative team. So here's a little snapshot of our timeline, where we are now and where we're going. So as I mentioned, July is when we started the study, and it's started collecting baseline data, and as I mentioned, started to vet our primary implementation strategies with our practitioners, and also that's where we've had the opportunity to learn additional strategies that we need to include in our ISTROM package. And as we go forward, starting in January of 2022 is when we plan to launch or deploy our tailored package of implementation strategies to our practitioners, starting with our initial training and educational sessions, as well as preparing our outcome measure champions. And ISTROM will be deployed throughout the course of 2022, and in 2023 start to evaluate the effectiveness of ISTROM to support practitioners' uptake of both the Fugl-Meyer and the ARAT. Which takes me into my last point here, at least when it comes to this one case illustration, and that is, well, how are we going to evaluate if ISTROM was actually effective for improving the use of our two outcome measures of interest? So we're going to talk about evaluating implementation outcomes as well as evaluating implementation determinants. But before I get into that, I do want to just reorient us back into this kind of implementation science logic model, to make sure that we're on the same page before I go any further. So on the left there, in that left box, you see the evidence to be implemented in this case is Fugl-Meyer and the action research arm test. We know from our systematic, or rather our scoping review, that our primary implementation barriers using CFIR language include access to knowledge and information, networks and communication, and implementation culture. Using the CFIR-to-ERIC matching tool, we've identified our primary implementation strategies, conducting educational meetings, preparing our champion, and creating our learning collaboratives, but through conversations with key informants and through focus groups with folks in acute, inpatient, and outpatient, we've learned of different, or additional rather, implementation strategies that we need to add to our ISTROM package. And the package of implementation strategies here is developed, of course, with the goal of improving the adoption of the Fugl-Meyer and the ARAT, as well as these three other implementation outcomes that I will talk about right here. So for adoption, which is our primary implementation outcome of interest, we are adopting, for lack of a better term, an interrupted time series approach. So retrospectively, we'll look at, prior to deploying ISTROM, to what extent did OT practitioners in acute, inpatient, and outpatient implement the Fugl-Meyer and the ARAT? And then we'll monitor if those rates of adoption increased over the course of us deploying ISTROM. And we'll keep our eye on those rates every month and provide feedback to practitioners to tell them how they are doing. Right now, in this baseline phase that we're in, we're currently also assessing appropriateness, feasibility, and acceptability of implementing the Fugl-Meyer and the ARAT. We're doing that qualitatively, but we're also doing it quantitatively through three measures. And the citation for those three measures is over there on the right by Brian Weiner and his team. And those three measures include the intervention appropriateness measure, feasibility of intervention measure, and the acceptability of intervention measure. And I bring those up, again, in the hopes that they are helpful to those of you who might want to include more quantitative measures into your implementation work. But these are measures that were drawn from the implementation science field. And also, if you go to this publication, you can download these 3 measures as an additional file. It comes up to you as a Word document, and the wording of each of these measures can be tailored and customized to the actual intervention or innovation that you want to implement. And so we're able to tweak the language in each of these measures to include terms that are more specific to the Fugl-Meyer and the action research arm test. And we'll be measuring those outcomes at baseline as well as at follow-up post-ISTROM. What's a little trickier is this piece here, and that's evaluating implementation determinants. So our determinants there on the left, not to be too repetitive, but again, our major determinants of implementation: access to knowledge and information, implementation culture, networks and communication. At baseline, we're measuring practitioners' perceptions of these determinants, drawing tools from publication and instruments developed by Maria Fernandez, her team. And then for networks and communication, we're drawing a tool from the quality improvement literature. And I bring this up because it's important for us to measure these implementation determinants at baseline and then measure perceptions of those determinants also at follow-up, because we need to know if our implementation strategies were actually effective for improving practitioners' perceptions of these determinants over time. Because if we don't know that, then we don't know if our implementation determinants have an impact at all on our implementation outcomes. And without that knowledge, it's hard for us to really think about the value of these implementation strategies in terms of closing the long-standing research to practice gap, which I'll talk about in a little bit here. But for example, to bring this to life a little bit more, we know that implementation culture is a barrier, as indicated through our scoping review, is a barrier to evidence use by occupational therapy practitioners. If we don't measure perceptions of culture at baseline and then again at follow-up, we don't know if our implementation strategies changed culture at all. And so we don't know if culture is even important in the grand scheme of our implementation efforts. I do promise that I'll come back to this whole concept of evaluating implementation determinants towards the latter portion of our time together today. But before that, I want to get into our second case illustration, which relates to the American Occupational Therapy Association's Knowledge Translation Toolkit. And the impetus for developing this toolkit was really grounded in this often cited statistic, which might not seem too surprising to many of you who've heard it before, is that it takes 17 years for scientific discoveries to be implemented in routine care. And that's from publication to use in practice. And that's a statistic that's over 20 years old. It's a statistic that I will admit I have cited recently. And I've been waiting for something to be released that is an update to this statistic that either says it's improved or it's worsened. Unfortunately, as of January of this year, the statistic has been updated. And now we know that it takes an estimated 15 years for scientific discoveries to be implemented into routine care. And that work was completed in the cancer care field back in January of this year. So, and if you're interested in that publication, you can check it out right there. And granted, this is an improvement to go from 17 years to 15 years, but it tells us that it's still important for us to leverage implementation science methodologies in order to narrow what's known as that research to practice gap, or narrow that 15 to 17 year time lag between publication of scientific discoveries and the use of those discoveries into practice. But still an improvement from 17 to 15 years. Still plenty of work to do. And this, I should also mention that this statistic is a statistic that plagues the entire healthcare field. Occupational therapy would be included in that, of course, and AOTA is very aware of that time lag and the difficulty of implementing evidence into practice, which is why AOTA, the professional body for the field of OT, decided to embark on this knowledge translation toolkit project and initiated it in 2019. And it was led primarily by AOTA's evidence-based practice division. And I should put in this disclaimer that when we think of knowledge translation is that broad term used to describe the process of creating evidence, applying it into practice, and then evaluating the extent to which it improves patient outcomes. Whereas implementation science is just a branch of knowledge translation underneath that knowledge translation umbrella. And so I was able to be part of this project, fortunately, because I was able to lend that implementation science perspective as this team developed their knowledge translation toolkit, or the KT toolkit, as you might hear me refer to it as. But the greater purpose of this toolkit was to create a collection of resources informed by stakeholder input and designed to help practitioners adopt evidence-based practices. And one other clarifying point is that when I say evidence-based practices, I'm not necessarily talking about that three-legged stool of client preferences, clinical expertise, and research, but rather I'm talking about the evidence-based interventions, evidence-based programs, screens, assessments, tools, those more tangible pieces that should be implemented with patient populations. So this knowledge translation toolkit, it's been 2 years in the works, and it has been released and published. This past July was published on AOTA's website. And so if you're interested in taking a look at it, you can go to aota.org and find the toolkit on the evidence-based practice and research page. So when we set out to develop this toolkit, we knew that there were several toolkits already in existence that have been developed to help practitioners implement evidence that might be specific to a certain patient population or medical diagnosis. But there were fewer toolkits out there designed to support practitioners' general use of evidence in routine care. And so even though there are those toolkits that were already in existence pertaining to specific medical conditions, there were few recommendations for how to go about developing your own toolkit. So fortunately, though, we came across this publication that came out in 2019 that addressed that knowledge gap of not having those recommendations for how to build or how to create a knowledge translation or an implementation style toolkit for use in practice. And so this publication did inform our development of the knowledge translation toolkit, and we drew down from this publication 6 different recommendations that guided our toolkit creation process. And here's what those 6 look like. First, we needed to explore the needs of potential toolkit users, which seems obvious, and I'll talk about that in the next slide here. We needed to incorporate theories, frameworks, and models. I'm sure you can guess what framework we used. We used the CFIR. We needed to search for existing tools to guide toolkit content. We were fortunate to collaborate and connect with leaders over at the Model Systems Knowledge Translation Center who've developed their own knowledge translation toolkit and resources specific to the treatment of burns, spinal cord injury, and traumatic brain injury. And so we're able to learn from their experiences and use those experiences to inform our own process of creating toolkit content. We also needed to involve expert stakeholders to review the content that we developed for the toolkit and make sure that it was digestible, understandable, and culturally appropriate. And right now, since the toolkit has been launched, we're in this phase of trying to figure out how we're going to pilot test the toolkit in practice and see the extent to which the toolkit is effective for improving practitioners' use of evidence in routine care. So we're going to circle back here to our evaluation of determinants of implementation. And unlike our prior study, our ISTROM study, where we conducted our scoping review to evaluate those determinants and to identify those barriers to implementation, in this case, we didn't necessarily want to sit down and collect qualitative data from practitioners, but rather we wanted to leverage AOTA resources, given that they are the professional body for the OT field, or the professional organization for the OT field. And so we wanted to leverage those resources and conduct a cross-sectional survey in order to gather a large sample, a large pool of data that could speak to the various determinants that influence OT practitioners' use of evidence into practice. So we conducted a knowledge translation survey, and it was informed by our awareness of common implementation barriers and facilitators. And in this survey, we asked practitioners to rank order the most pressing or the most concerning implementation barriers, as well as the most helpful implementation facilitators. But we also allowed practitioners to provide narrative comments so that they could expand upon potential barriers that they were facing in their efforts to use evidence in practice. And on the flip side, they could also explain what facilitators supported their use of evidence. We disseminated this survey from August to September of 2019 through AOTA's different social media channels, as well as directly on aota.org, and also disseminated it through more OT-specific forums that were online forums. And in total, we yielded a response rate of, or responses that include 836 participants. Of those participants, the slight majority held master's degrees, primarily though representing the areas of children and youth and rehabilitation and disability. And we know from AOTA's most recent workforce and salary survey that those professional demographics are fairly representative of the OT profession as a whole. And we wanted to gather input from practitioners who were new grads, all the way up from those practitioners who had upwards of 30 years of experience or more. And so when we look at our top barriers to evidence use, we see that of those rank ordered barriers, of no surprise here, there's a lack of time to stay updated on evidence. Practitioners felt they had a lack of resources, equipment, or space to use EBP as it was originally intended. Difficulty accessing research articles and databases that was particularly challenging for those practitioners who were coming from organizations or clinics or units who maybe were not affiliated with something like an academic medical center and didn't have access to journals or databases that required a paid subscription. And then lastly, we see that insufficient administrative support was our fourth major barrier. So from our survey findings, and with our top rated barriers in mind, we also wanted to make sure though that we evaluated the narrative comments that were provided to us, because our practitioners did not hold back. And so we used a directed content analysis and mapped those data back to the Consolidated Framework for Implementation Research. And with those data mapped back to the CFIR in combination with those top rated barriers, we were able to identify really the most pressing barriers that impeded practitioners' use of evidence in occupational therapy practice. And those major barriers included knowledge and beliefs, which is a construct that falls in the individual characteristics domain of the CFIR, access to knowledge and information, available resources, leadership engagement. Those three represent constructs in the inner setting domain of the CFIR. And then lastly, adaptability, which pertains to the characteristics of the intervention of the CFIR, was our last major barrier. And that adaptability piece is really a complex process because it's challenging to adapt an intervention while also holding true to the core components that deem that intervention effective. And so while we have tried to provide in the toolkit our practitioners resources to help them think about intervention adaptation, I also just wanted to say this disclaimer that we're still working on determining the best strategies to help practitioners adapt evidence for use with diverse patient populations and in diverse contexts. So with these major barriers identified, then we can move into this phase of selecting implementation strategies. And in this case, you have to think about implementation strategies in a different way than in our previous ISTROM study. In the ISTROM study, we were deploying a package of implementation strategies at one single site, and those strategies were designed to be more dynamic and more interactive, with direct involvement from the research team as well as directly with our practitioners. In this case, AOTA is attempting to develop a collection of resources, and those resources are developed to help practitioners and administrators then deploy strategies in their own settings and in their own unique context. So it's a little bit of a mind shift that you have to make when thinking about how these strategies are being developed for our practitioners. So we resorted back to our CFIR-to-ERIC matching tool in order to select these different implementation strategies. And again, we're developing resources to help practitioners use these strategies in practice. So we've got the CFIR as our determinant framework, the ERIC as our strategy framework, and in combination, we're able to identify several implementation strategies to ideally overcome implementation barriers. So from our CFIR-to-ERIC tool output, we see that we need to develop educational resources that help practitioners locate evidence and appraise it. We also need to develop resources to help practitioners capture and share local knowledge, to develop learning collaboratives, to help prepare their organization to be ready to implement evidence into practice. We also know that we need to develop resources to help build capacity for implementation champions, or EVP champions. We also know that practitioners need assistance securing funding to pay for training, to pay for equipment and other resources. And then, as I mentioned before, we know that practitioners need resources to help them adapt interventions into practice. We're able to provide a couple examples of how those adaptations have looked in the past in the literature. But again, this is kind of a work in progress, and there's no real clear-cut, concrete way or answer right now, at least, for us to give to practitioners so that they can adapt evidence into practice, and while still holding true to those core components that deem an intervention actually effective. And with all this language on the screen here on the slide, it might seem somewhat foreign, and we were mindful of that. We were mindful of the needs of practitioners, and know that practitioners might not have the time, the ability, or the interest to learn about the language in the CFIR, to learn about the language in the ERIC taxonomy. And I know that at the beginning of this talk, I was raving about how great it is to have language that we can anchor to and helps us explain and communicate what we do in implementation science. But again, that language might be too unfamiliar to practitioners that just want help implementing occupational therapy interventions and services into practice. And so with that in mind, we knew we needed to kind of reorganize these different resources and reorganize or think about the types of language that we're using to explain these tools that we're including in our knowledge translation toolkit. And so we went ahead and reorganized these into 4 different categories, or 4 different buckets. And so this is how the content is organized on AOTA's website, on our knowledge translation toolkit platform. And that first bucket there, getting started with EVP. And so that's where you'll find all those resources that pertain to conducting a literature search and appraising evidence and determining if an intervention is actually worthy of being implemented into practice. Changing your own practice, we've provided practitioners with 1 to 2 examples for how work or how evidence has been slightly tweaked so that it can meet the needs of the local context or the needs of actual patient populations. But again, that's also a work in progress here. That third bucket, influencing change in your organization, that's where you'll find resources that speak to obtaining funding for training and for equipment, for improving EVP readiness within your organization, and for building your capacity for evidence-based practice champions. And then with knowledge sharing, we've developed templates as well as worksheets for how you can capture and share local knowledge. So really leveraging the talents of your practitioners around you, and also how you can go about building and creating a learning collaborative amongst your own OT colleagues, as well as interdisciplinary colleagues as well. So let's reorient us all here and go back to our main recommendations, our 6 recommendations for building this toolkit, and look at what we've done and where we're going. So we conducted our cross-sectional web-based survey, which means that we explored the needs of our potential toolkit users of our OT practitioners. We've incorporated the CFIR to help guide our analysis of the data that we drew from that knowledge translation survey. We collaborated with folks who have experience developing toolkit content and learned from those experiences, and those experiences informed our own processes of putting together our resources. And now we're at this point where we need to make sure that the resources that we have developed are reviewed by expert stakeholders, and those stakeholders represent the fields of the areas of OT research, OT practice, as well as OT education. But we were also able to pull in some physical therapy expertise as well in order to get that interdisciplinary perspective reviewing our content. We pulled these stakeholders in, of course, because we want to make sure that our content is understandable on behalf of practitioners as well as culturally appropriate and relevant. So looking at 4 and 5 right there, I want to break that down a little bit further and tell you how we actually had our expert stakeholders review our different knowledge translation toolkit resources. So first, our knowledge translation toolkit team went ahead and developed resources based on findings from that CFIR-to-ERIC matching tool, those strategies, and also based on evidence as well as our own clinical expertise. The AOTA team internally reviewed those resources, provided feedback to the greater knowledge translation toolkit team, and that feedback was used to revise resources before those resources were then sent out to our external stakeholders. And then following a similar process, our external stakeholders reviewed the resources, provided feedback to us. We embedded that feedback into our revisions of our different resources. And then finally, once approved by the whole knowledge translation toolkit team, as well as by AOTA, the combination of resources was posted on AOTA's website in the knowledge translation toolkit platform, which looks something like this. So I highly recommend that you check it out. I should mention that this is a work in progress, meaning that we will continue to add to this knowledge translation toolkit. It's not a one and done type toolkit. We're looking for strategies to build upon this work. We're also looking for recommendations as to other types of resources and tools that might be helpful to the OT profession. So feel free, if you do have ideas as to how this can be further enhanced, if you go to this website, you'll see an email that you can reach out to with those ideas. And if you have interest in our methods for building this knowledge translation toolkit, those methods will be published in a JOT, the middle of 2022. But if you don't want to wait that long, you can, of course, reach out to me if you don't want to wait that long. And I'm happy to share with you the methods directly. All right, so as we get to think about moving forward and evaluating the effectiveness of our knowledge translation toolkit, we don't want our 2 years worth of efforts to just be frivolous. And so we want to make sure that our knowledge translation toolkit is effective for improving practitioners' adoption of evidence into practice. And that was the main goal. The purpose of the knowledge translation toolkit was to create a collection of resources to help practitioners adopt evidence-based practices. And the resources included in the toolkit have been purposely designed based on what we know from the CFIR-to-ERIC matching tool and those recommended strategies, that the resources included in the toolkit should hopefully help practitioners overcome barriers of a lack of knowledge and beliefs about using certain interventions into practice, a lack of access to information, lack of available resources, leadership disengagement, and then the difficulties that come with trying to adapt evidence into practice. So knowing that these are our main determinants, our major determinants, and knowing that the AOTA knowledge translation toolkit is supposed to help practitioners address these determinants or overcome these barriers, we have to ask ourselves, well, how do we go about measuring these determinants? This is the last resource that I'll share with you, but hopefully this will lead to a discussion about measurement and about measuring specifically implementation determinants. But the Society for Implementation Research Collaboration is its own group, its own website. It consists of implementation scientists, primarily who are interested in implementing evidence-based practices in those fields that pertain to mental and behavioral health. And specifically, there's a group who has taken on this instrument review project, and this project is led by Dr. Kara Lewis. And the goal of this project is to review the implementation literature, or review the literature in general, and determine what instruments are already in existence that have been used to evaluate implementation determinants, as well as implementation outcomes. And this work has been going on since about 2015 and has been funded through the NIMH. And this team of implementation scientists has really made quite some impressive progress towards putting together this collection of tools to help us measure implementation determinants. And so if you go to the CERC website and you click on their instrument repository, you're directed to a table that looks something like this. So in the first section of that table, you see in that left-sided column, implementation outcomes. If you were to click on any of the 8 implementation outcomes on the right, then you'd be led to a page that lists out different instruments that have been used to measure implementation outcomes. But we won't focus on outcomes today. Again, that's a talk in and of itself. But rather, if you look at the bottom portion of that table, where it says inner setting on the left, and you've got on the right, the 15 or so different inner setting constructs of the CFIR. So if we think back to our major determinants that influence evidence implementation as perceived by occupational therapy practitioners, we know that leadership engagement was believed to be one of those determinants, or a lack of leadership engagement was believed to be a barrier to implementation. So we click on that, and that takes us to this, something at least that looks like this on the next page, which lists out 5 different instruments that have been identified from the literature that speak to evaluating leadership engagement. And in addition to just listing out these 5 different instruments, The instrument review team has also described the psychometric properties as well as the pragmatic qualities of each of these individual instruments. And those pragmatic qualities might include factors that pertain to the cost of acquiring the instrument, might pertain to required training to implement the instrument with actual patients or providers, and then also the burden that it might have on practitioners to interpret findings from each of these different tools. And I have found this website to be incredibly helpful as I've tried to find measurement tools to help evaluate changes in perceptions of implementation determinants. But this instrument review team themselves have indicated that there's still much work to be done in the space of building the strength of measurement tools in implementation science, specifically tools that pertain to measuring implementation outcomes and implementation determinants, such as those determinants that we see in the CFIR. And it's important to recognize that because without these high quality tools, we don't know what determinants or what factors are associated with the successful or in some cases unsuccessful implementation of evidence-based interventions in programs and routine care. And so we need tools to help us be able to do that. And we need tools, of course, that are of high quality. And so to address that need, we need targeted, interdisciplinary, and coordinated efforts to not just develop new tools that help us measure implementation determinants and implementation outcomes, but we also need to test existing tools and test the psychometric properties of those tools amongst different populations and in different settings. And I bring this up because I find implementation science to be exciting. It's a rapidly evolving field, and I love pulling it into the work that I do in rehabilitation, as well as the work that I do in the space of geriatrics. But without sound, valid, reliable tools to help us measure implementation determinants, we don't have a solid measurement foundation in implementation science. And without that solid foundation, that undermines the field as a whole and threatens the credibility of our implementation findings. And so as I've been thinking about these measurement issues in implementation science, especially as we've launched iStrom and been thinking about how we're measuring implementation determinants, I've started to think, not necessarily what can implementation science do to advance the field of rehabilitation, but rather what can rehabilitation do to advance the field of implementation science? And I say that because we are trained to be evidence-based practice implementers. And many of us have a deep appreciation for the multi-level barriers and facilitators that have influenced our efforts to implement evidence in the practice. And I'm sure many of you can relate to the story that I initially shared at the beginning of our time together today. And we're also a group of rehabilitation professionals who are very accustomed to working in an interdisciplinary fashion, collaborating with others. We're a group that's used to collecting information and data. And so why can't we collaborate with one another, collaborate with psychometricians? We have several experts in OT with expertise in instrument development, Jen Weaver, Brittany Hand, Craig Veloso, to name a few. So why don't we work together? Why don't we collect data from ourselves, from our health systems, leverage the power of rehab, and try to address these measurement issues that are plaguing the implementation science field? Because if we don't have strong tools to measure our implementation determinants, then we won't know if our implementation strategies are effective for improving implementation barriers, and we won't know if implementation determinants can lead to improvements in implementation outcomes. And without that knowledge, it's hard for us to move the needle on closing the now 15-year, but still problematic research to practice gap. And so I would love for our conversation to continue about the CFIR, about measuring determinants, or about anything else that might interest you in implementation research. So thank you again for tuning in, and very much looking forward to our discussion time together.